Alright, here's the next video for pharmacology. You can do chapter 27, dysrhythmias. There's really only one slide that, through the notes in the class, that we have to know. It's going to be a select all that apply, is what I have starred in my notes here. Actually, 2 slides, and we'll get into that. What I did here is I did go through some of the pathophysiology slides that she posted for the cardiac system, just because I think if you look at those things and you kind of think about the mechanics of how things work, you can really sort of dig into the weeds and understand why there are certain types of dysrhythmias, or not dysrhythmias, but anti-dysrhythmics that exist. So you can skip ahead if you want to those, but I don't know where they're going to be because this is the first time recording. Pro tip again, or not again for the first time, so this is video number 2. Put this shit on like 1.5 times feedback and slow it down when you want to. That being said, let's get started. So objectives: understand how dysrhythmias affect heart rhythm, heart rate, or both. Apply pathophysiology, clinical manifestations, non-pharmacologic management, and drug therapy to care of patients with dysrhythmias. Next, overview of dysrhythmias. Electrophysiologic conduction system. 4 events: stimulation from electrical impulse, transmission of electrical impulse to adjacent conductive or contractile tissue, contraction of atria and ventricles, and relaxation of atria and ventricles. Basically what that's saying is we have the signal from either the brain or the SA node that initiates the impulse, SA node, sorry, just had to double check. The impulse that runs the electricity through the nerves in the heart causes the contraction of the atria, which are up top, and then the ventricles, and that's it. There's a certain way that this is supposed to happen. If it doesn't happen this way, that's when we have dysrhythmias, and they have all sorts of issues that come along with them. So yeah, automatically generate electrical impulse from the sinoatrial node, or the SA node. That's the fastest. Conductivity, cardiac tissue transmit electrical impulses. So that's what's neat about cardiac tissue, is that it's a striated muscle tissue, and if you look at it, it's got like these little, basically, fingers at the end where they all connect together, and they can run electricity through them rather than actual nerves that would innervate like a normal skeletal muscle cell. So that's super neato. Ectopic beats, SA node fails to fire impulse or too slow, and then tachydysrhythmias or bradydysrhythmias, so either dysrhythmia is too fast or it's too slow, and can be asymptomatic or symptomatic: hypotension, dizziness, SOA, chest pain, oliguria. Alright, so this slide is from the pathophysiology slides. This is just structure of the heart. So you have right atria, right ventricle, that basically blood comes in from the vena cava, goes to the atria, goes to the ventricle, gets pumped out through the pulmonary artery, gets to the lungs, it's oxygenated, comes back in through the pulmonary veins into the left atria, down into the left ventricle, and then is pushed out through the aorta to the body. So that's pretty simple. We have a few little waves here, A, B, and C, talking about the, it looks like maybe polarization of the SA node and the AV node, and Purkinje fibers. So that's pretty simple stuff. I don't know. Oh, action potentials, we don't really need that. This is what a normal electrocardiogram looks like. P, Q, R, S, and then T is repolarization, and then U. Pretty standard stuff here. don't get too caught up in it. Just if it doesn't look like this, and I don't think we're gonna have to look at any electrocardiograms and figure out, well, what are they in. But we'll see. So just be prepared. So cardiac cycle again, we already talked through that. And then this is one, I think, yeah, I pulled this one from, I want to say, the pathophys. Let me look at my other screen here. Yes, this is from the pathophysiology. I pulled this because we're going to get into the medicine list next, and it makes sense to have this because they all have to do with which ions that they inhibit from being passed through whatever part of the cell or the heart that's going on. So this is really the big one that's going to help you out here. So how would each of the following affect heart contraction? Calcium channel blocker, calcium ions enter the muscle during this phase of the action potential, play a key role in the contractile process of cardiac muscle fibers. Sodium channel blocker, potassium, and calcium ions are major electrical charge carriers in cardiac muscle cells. A drug that opens sodium channels, some anti-dysrhythm, and then a drug that opens potassium channels. Oh, that's a question. The answer, no, that's not a question. That's later. Okay, so those are all things you have to think about. So in a standard muscle cell, there's what's called the sarcoplasmic reticulum, and it basically stores calcium ions, and then they get released. They go down and change the structure of the thin and thick filaments inside, so myosin, actin filaments inside a muscle, and that's what the striations are in the muscle cells. The heart's no different. And they allow the myosin to grip the actin when the calcium binds. So calcium's super important in muscle contraction, especially in striated muscle, so skeletal and cardiac muscle. So have that in the back of your mind. And then also you have sodium, potassium. Those are the two main ions that are used to set up electrochemical gradients on nervous cells. And as we've already established, cardiac cells can conduct electricity, just as like nervous cells do. So they send those impulses, and those are why they're needed to continue doing what they do. So that gets us into the medications here. So the first type is class 1A. One second, I got a belch. I don't want to do that. Sorry. Class 1A, quinidine or quinidine. I don't know how you say it. It's for AFib. She definitely mentioned knowing this. So just sodium channel blockers are class 1. Like I said, sodium has to do with electrochemical gradients. So sodium channel blockers, quinidine for AFib. Class 1B is lidocaine. We talked about that. So like for ventricular tachycardia, I want to say that's where you're going to see it. We talked about how there are certain other medications that have lidocaine in them, and there are contraindications for using them, like somebody's in shock or has a ventricular block or something like that. I can't remember exactly what it was, but lidocaine. And then whatever 1C is flecainide or Tamacor. I have no idea. It just is a sodium channel blocker. I don't know what the indications for it are, and they're not in here. I'm not going to look up. So there you go. So beta blockers are class 2. We've already talked about last video in hypertension. Class 2, propranolol. It's used when we have angina, so chest pain. That chest pain's coming from an occlusion of the cardiac arteries or whatever, usually on exertion until it gets really occluded. If we go back up here, so we're still on the same, we look at, well, they decrease cardiac output, contractility, and suppress reflex tachycardia. So basically it's going to cause the heart to not the heart muscles to not squeeze as hard. So beta blockers are class 2, potassium channel blockers class 3. Amiodarone is for VFib and VTAC. So amiodarone, again, class 3 potassium channel blockers. We talked about potassium, again, and its polarization of nervous cells and setting up electrochemical gradients, so that's why that's important. And then finally, I already went through calcium and its importance here, so that's class 4. So class 4 is calcium. And I think really, if I look at it, I look at I think sodium is chemically smaller than potassium, and then potassium is chemically smaller than calcium. Calcium is also a +2 charge, so I kind of think sodium's going to be the class 1s. We'll skip class 2. We'll just call beta blockers class 2. Potassium's going to be class 3, and then class 4 is going to be calcium channel blockers. And I think if you look at a periodic table, I want to say second row down is sodium, and then potassium's under that. Don't quote me on it. I haven't looked at a periodic table in a hot minute. But anyway, so calcium channel blockers, class 4. Diltiazem or cardizem is for AFib and verapamil. So diltiazem and verapamil, AFib, for calcium channel blockers. And then we have these unclassified, so adenosine and sotalol. I don't know. I'm not looking them up because they're not, there's no information on them. So the other thing we have to know, I'm going to go ahead and highlight all this. Adverse effects and nursing considerations. And I think it's probably respectively. So adverse effects are hypotension, obviously. I don't know what HF is. Just another abbreviation. Bradycardia, again, dizziness, muscle weakness, anxiety, insomnia, confusion, slurred speech, seizures, fatigue, liver toxicity, AV block, and other dysrhythmias. So I think about it this way, if you're changing the way the heart contracts and you're making it contract less, say with a beta blocker, and we already know that beta blockers cause hypotension. You can look at it this way, hypotension is a drop in blood pressure. Bradycardia is a drop in pulse rate. Both of those things are obviously going to cause dizziness. Probably cause muscle weakness because blood perfusion to the muscles isn't going to be as good, so oxygenation is going to go down. I don't know if you've ever been strangled or almost drowned, but also when you are short on air supply, you get anxiety. I have no way to remember insomnia. Just remember insomnia. Confusion goes along with hypoxia. Slurred speech goes along with hypoxia. Seizures probably goes along with hypoxia. Fatigue goes along with hypoxia. Liver toxicity, well, what doesn't hurt your liver anymore? AV block, just remember that, and other dysrhythmia as well. If you're using something that's going to fix one dysrhythmia, chances are it could also cause another one. You might go from one end to the other and skip over normal. So just think about that for adverse effects. And then for nursing considerations, monitor vitals and ECG. Bottom line is if you're giving these drugs in a hospital setting, they're probably going to have telemetry ordered. If they don't have telemetry ordered before you administer these drugs, then you should probably be like, hey, doctor, let's put some telemetry on these people. So monitor for signs of HF. I guess I'm going to have to Google. Hang on. It's heart failure. Sorry, I'm dumb. Should have known. I should have known. Okay. Yeah. Okay, monitor vitals, ECG, monitor for signs of heart failure, assess for fatigue and shortness of breath up here already, monitor for CNS effects already up here, and then teach orthostatic precautions and signs of heart failure. So there you have it. And then I think there's one question I just pulled from the patho slide. So which ion channels allow cardiac muscles to fire without a stimulus? Calcium. Rationale. On the SA node and AV node, resting cardiac muscle cells have an open calcium channels. This allows calcium to leak into the cells, making them more positive. The cells reach threshold this way without the need of a stimulus. So there you have it. Let's go back over this one more time. Class 1, sodium channels. So sodium is going to be first. Class 1A, quinidine for AFib. Class 1B, lidocaine. Blocks pathway to return to normal rhythms. And 1C, flecainide or Tamacor. Beta blockers, class 2, propranolol. Why am I not saying it? Am I having a stroke? Okay. It's for angina. Class 3, amiodarone, VFib, VTAC. It's a potassium channel blocker. Class 4 is a calcium channel blocker. Diltiazem or cardizem, and then that's for AFib. And then there's unclassified adenosine and sotalol. So that is it for this video. Thanks. I mean, I guess no thanks. Not like it fucking matters, but I guess I should stop cussing. Whatever. Who cares?